Hi, my name is Namita Isa, and this is my checkoff. The 8 pre-procedural steps are: first, you're going to check on nursing orders and plans. Then you're going to gather all supplies and equipment. You're going to wash your hands and maintain standard precautions. Then you're going to introduce yourself to the patient. You're going to check 2 patient identifiers like their name and date of birth. Next, you're going to provide privacy by closing all curtains and shutting all doors. Then you're going to educate the patient on the procedure. Then you're going to raise the bed to an appropriate height. So first, we're going to start off with the neurological assessment. So based off of appearance, we can see that the patient is appropriately well-dressed and well-groomed for the weather. His posture is erect. His level of arousal is that the patient is alert. His affect and his mood is appropriate for the situation. Next, we're going to go on to JOMAX, which assesses the cognitive thinking. We're going to start off with J, which is judgment. This tests for impulsiveness and his goals. So, Mr. Iso, what would you do in a fire?
I would run.
And what are your goals after you graduate college?
Apply for my master's.
Great. So next we're going to go on to O, which is orientation. We want to make sure the patient is oriented to person, place, time, and situation. So Mr. Issa, who is the President of the United States?
Donald Trump.
And where are you right now?
In my house.
What time of day is it?
Morning.
And what are you here for?
Physical examination.
Great. So now we're going to go on to M. M is memory. You want to test for the patient's recent memory, remote memory, and immediate memory. So Mr. Issa, I'm going to say a sentence and I would like you to say it back to me. All dogs go to heaven.
All dogs go to heaven.
And what was the weather like yesterday?
Sunny.
And when is your birthday?
March 29th.
Great. So now we're going to go on to A, which is attention span. We can see that Mr. Iso is able to concentrate and he has ability to follow directions and learn. Next, we're going to go on to C, which is cognition. We know that Mr. Iso has the ability to understand what he's being told, and he has coherent thought processes. Next, we're going to go on to S, which is speech. Mr. Iso's speech is fluent and is coherent, and it has appropriate rate and rhythm. Next, we're going to go on to the cranial nerves. We're going to start off with the first cranial nerve, which is olfactory. So, Mr. Iso, if you could please plug in one nostril and tell me what you smell.
Alcohol.
Great. And plug in the other nostril. And what do you smell?
Alcohol.
Great, so the first cranial nerve is intact. Next, we're going to go to the second cranial nerve, which is optic, and this tests for visual acuity. So, Mr. Issa, if you could please stare over there at an object, and if you can take off your glasses. Great. So we can see from doing the visual acuity test that his pupils are equal, round, reactive to light, and accommodate consensually, and the red reflex is centralized and intact. Next, we're going to check for cranial nerve 3, 4, and 6. Cranial nerve number 3 is oculomotor, cranial number 4 is trochlear, and cranial number 6 is abducens. So we're going to do these by the cardinal gazes. So, Mr. Iso, if you could please stare at my finger and make sure you do not move your head. Great, so based off of the cardinal gazes, we can see that the patient has no nystagmus. Cranial nerve number 3, we have to make sure that we make the eye movement is going medially, down, and lower laterally. And then for cranial number 4, we have to make sure that it's going down, and then for cranial nerve number 6, we have to make sure that he has intact eye movement laterally. Next, we're going to go on to cranial nerve number 5, which is trigeminal. So, Mr. Iso, if you could please chew, like pretend that you're chewing, and clench your jaw. And then if you could please open and close your mouth. Great. So now we can see that this cranial nerve is intact. Next, we're going to go on to cranial nerve number 7, which is facial. So, Mr. Iso, if you could please smile, and then show your teeth, and then frown, and then raise your eyebrows. Great. So Mr. Iso was able to do all of these tests without any difficulty, so therefore cranial nerve number 7 is intact. Next, we're going to go to auditory, which is cranial nerve number 8. So Mr. Iso, if you could please plug in one ear, I'm going to whisper something into this ear, and please recite it back to me.
A, B, C.
Great. So if you could do that to the other side.
1, 2, 3.
Great. So now we know that cranial nerve number 8 is intact. Now we're going to do cranial nerve number 9 and number 10 together. Cranial 9 is glossopharyngeal, and this we will ask the patient to say ah, and then cranial number 10 is the vagus nerve. So Mr. Iso, if you could please open your mouth and say ah. And please stick out your tongue. Great. So now we can see that there was a rise and fall of the soft palate, and his uvula is midline. Next, we're going to go to the spinal accessory, and this is where we're going to ask Mr. Iso to shoulder shrug. So Mr. Iso, if you could please elevate your shoulders, and do not let me press down, and if you can please shrug your shoulders, do not let me pull it back up. So now we can see that cranial nerve number 11 is intact. Next, we're going to go on to cranial nerve number 12, which is the hypoglossal. I'm going to ask Mr. Iso if you could please stick out your tongue, and then if you could say these 3 words: light, tight, and dynamite.
Light, tight, dynamite.
You can say it putting your tongue back in.
Light, tight, dynamite.
Great, thank you. So now we can see that cranial nerves number 12 is intact. So next we will be assessing for the sensory nerve function. So we're going to see if Mr. Iso can assess to pain. So Mr. Iso, if I could see your hand, and then close your eyes. And is this a sharp or dull pain?
Sharp.
And then what about now?
Dull.
Great. So now we're going to do the light touch. So Mr. Iso, if you could please close your eyes and tell me what you feel.
Light.
Great. And where do you feel this?
Right cheek.
Okay, good. Next, we will be assessing for the patellar reflex. So first, you would use a hammer, but because I don't have a hammer, I'm going to use my stethoscope. So you want to make sure that you find the bend of the knee. So Mr. Iso, if you could please bend your knee. And then you want to make sure you hit it. You did it before I hit. Damn it!
Just keep going, just keep going.
So now we will be assessing for the patellar reflex. You want to make sure that you use this with a hammer, but because I don't have access to an hammer, I'm using my stethoscope. So you want to find the bend of the patient's knee, and then you want to hit it. And then you want to make sure that you do this on both sides. So we can see that his reflex is 2+. Next, we'll be doing the plantar reflex. So another thing to know about the plantar reflex is all babies up to the age of 6 months have a positive Babinski sign. And this means that their toes flare out. For an adult, a positive Babinski sign is when their toes flare out, and that is abnormal for adults. So Mr. Iso, if you could please extend your leg. And then we can see that his toes curl, and therefore he has a negative Babinski sign. So next we're going to assess for motor function. We're going to check for Romberg. So Mr. Iso, if you could please stand up. And then close your eyes. So here we see that Mr. Iso is not wavering or not swaying, and he's being very steady. And I have my 2 hands out in front of him and behind him as a safety precaution. So Mr. Iso, you can sit back down. And then next we're going to check for coordination. We checked in the musculoskeletal system assessment that the patient was able to have a good gait, and he had a very rhythmic gait, so he was steady. So Mr. Iso, if you could please go like this. So then this shows that he has rapid movement coordination. Next we'll be going on to the cardiovascular assessment. In a clinical setting, we would want to make sure we drape the patient and provide privacy, but for demonstration and video purposes only, our patient is clothed. So upon inspection, we should see that the chest is symmetric and that there are no physical scars, no nodules, no lesions, no lacerations, no masses, and no deformities. The location of the heart we need to know. So the left side of the heart is posterior and the right side of the heart is anterior. The base of the heart is on the right sternal border, and the apex of the heart is in the 5th intercostal space, mid-clavicular. Next, we can now auscultate. So we want to get our stethoscope. We need to know that the S1 is the sound of the closure of the AB valves, and S2 is the sound of the closure of the semilunar valves. So what we want to do is we want to take our stethoscope, and as I said, for video demonstration, the patient is clothed, but in a clinical setting, you do want to make sure that you listen underneath the clothes. So we want to check for the 2nd intercostal space on the right side. This is the aortic, and this is where you will listen to S2. Then you're going to go on to the left intercostal space, left 2nd intercostal space, and this is pulmonic, and this is where you'll listen to S2. Next, you're going to go down to intercostal space 3 on the left side, and this is where you'll hear Erb's point, and this is where you'll hear S1 and S2. Next, this is on the left side, fourth intercostal space, and this is where you'll hear the tricuspid, and this is where you'll hear S1. And then the fifth intercostal space on the left side is the mitral, and this is where you'll hear S1. So now we will check for the pulses. So Mr. Issa, if you could please sit on the bed. So for the pulses, we want to make sure that they are all 2+. So we're going to start off with the carotid, and now the other side. Next, we're going to do the brachial, and then the radial. We want to make sure that we would do this on both sides. Next, we would do femoral. I'm not going to do it for video demonstration purposes only, but the femoral is right here, and we would want to make sure to do it on both sides. Next, we will do the popliteal, which is behind the knee. Next, we will do the dorsalis. And then next, we'll do the posterior tibialis, and we want to make sure that we do it medially and not laterally. Next, we want to make sure to assess the neurovascular. So we just did our pulse assessment, and they were all 2+ and present. At the beginning of the assessment, I asked the patient if he was in any pain, and patient denied any pain. Next, we checked for pallor, and we made sure there was no visible pallor anywhere. And patient denies any numbness, so there's no paresthesia. And then patient had no difficulty moving any extremities or any part of his body, so therefore there's no paralysis. Now we will check for edema assessment, and I have checked, and there's absence of any edema. Next, we will check for capillary refill. And we can see that the capillary refill is less than 3 seconds. Next, we will be checking for temperature on the dorsum of the hand, and temperature is warm and appropriate. Next, we'll be doing the respiratory assessment. So for inspection, we know that on the right side there are 3 lobes. There is the upper, middle, and lower. And then on the left side, we know that there's superior and posterior, and there are only 2 lobes. This is due to the position of the heart. We also want to know that the chest is symmetric and there are no visible masses, nodules, or deformities or scars. Next, we want to make sure to check for the A and P diameter. So what this means is you want to take your stethoscope, and the anterior aspect and the posterior aspect of the chest should be 2 times the length of the lateral aspect of the chest, and it is. So it should be a 2-to-1 ratio. So next, we want to make sure that our patient has no facial distress, no nasal flaring. The patient has no labored breathing, and his breathing is regular rate and rhythm. We also know that there's no use of accessory muscle use, and there's no intercostal retractions. We also can see that the spine is erect and the patient is not in a tripod position. Next, we're going to palpate. We're going to palpate first anteriorly. For demonstration reasons only, we have the patient clothed, but in a clinical setting, we want to make sure that we provide privacy and listen underneath the shirt. So as we palpate, we can see that there is no tenderness. I don't feel any masses or any lumps. So next, we will be listening to the 5 spaces anteriorly. So when we listen, we want to make sure that we listen after each breath. 1 breath is 1 full inspiration and 1 expiration. For video and purposes only, I'll be just showing you the pattern, but I know that we have to do it after every inspiration, expiration. So those are the 5 spaces for anteriorly. Next, we'll be checking on the posterior side. So we can see that it is symmetric. There are no masses, there are no visible scars or anything like that. In a clinical setting, we would make sure that the patient is unclothed, but for demonstration reasons, we have the patient clothed. So now we can palpate and see that there are no masses or lumps or nodules, and there are no scars. So next we're going to listen, and we're going to listen to all 9 spaces. We want to make sure that we do this after each inspiration and expiration, but due to video purposes, we're just going to show you the pattern. So that was all 9 spaces, and we can see that there was no adventitious sounds, there was no rails, there was no ronchi, and there was no rhesus. So next we will be doing the percussion part of our assessment. Here we want to make sure we know that dullness replaces resonance when fluid or solid tissue is present. So when we hear resonance, it's over an air-filled, and then when we hear dullness, it's over a fluid-filled or solid tissue presence. So we want to make sure that we do the same percuss technique over all 9 spaces. So now we can go on to the tactile fremitus. So I'm going to put my pinky side towards the skin, and I'm going to ask my patient to say 99, and we should be able to feel the vibration. So Mr. Iso, if you could please say 99,
99,
99,
99,
99,
99,
99,
99,
99,
99,
99,
99,
and 99.
99.
Great. So I was able to feel the vibration in the posterior side. Next, we're going to do chest expansion. I'm going to put my hands on his lower abdomen. I'm going to ask him to inhale and exhale, and I should see my hands move up and down like this. So Mr. Iso, if you could please inhale and exhale, inhale and exhale. So yeah, my hands were able to move up and down. Next, we will do the abdominal assessment. Before we even start, I assisted my patient into the supine position and made sure his arms are at his side and his knees are slightly bent. In a clinical setting, we would make sure to provide privacy and drape the patient, but for video purposes only, my patient is clothed. So upon inspection, we can see that the abdomen is flat and symmetrical. The skin is intact. We can also see that there are no visible masses, no visible nodules, hernias, ecchymosis, peristalsis, no striae, and no visible scarring. And there are no visible venous patterns. Next, we're going to auscultate. We want to make sure that we auscultate before we percuss and palpate, because we don't want to unintentionally falsify active bowel sounds. So we want to hear normal bowel sounds, and this is between 10 to 30 bowel sounds per minute. Hypoactive bowel sounds is less than 10 bowel sounds per minute. Hyperactive bowel sounds is greater than 30 bowel sounds per minute. And sometimes there can be an absence of bowel sounds. So if this happens, you want to make sure that you listen to all 4 quadrants for 5 minutes. So when you're assessing the abdomen, you want to make sure you start in the right lower quadrant. You want to start here because this is where you can most clearly and hear the bowel sounds. This is also where the opening and closing of the ileocecal valve is. So we're going to auscultate for all 4 quadrants. We're going to go to the right lower quadrant, right upper quadrant, left upper quadrant, and left lower quadrant. So I'm going to take my stethoscope. Once again, we would do this not clothed, but for demonstration reasons, we're going to clothe my patient. So we're going to be in the right lower, right upper, left upper, and left lower. So my patient had normal active bowel sounds. Next, we will be going on to palpation. We want to make sure that we go into palpation from a light touch to a deep palpation. For video purposes, we're going to go to to a light touch. When we are palpating, we want to make sure that we don't go like this when we're palpating and use two hands and really feel. And then when we're feeling, we want to make sure we know what organs we're feeling for. So here in the right lower quadrant, we're supposed to be feeling for the cecum and the appendix. In the right upper quadrant, we're supposed to be feeling for the liver and the gallbladder. For the left upper, we want to feel for the stomach and the spleen. And then for the left lower quadrant, we want to feel for the descending colon and the sigmoid colon. So from the palpation, we can see that all organs are non-palpable. Next, we'll be going on to percussion. So for percussion, we want to hear tympanic sounds. We want to make sure it is it's heard over the organs and the GI tract. No dullness should be heard over, because it will be, if you hear dullness, it's usually over a fluid-filled organ like the spleen or the liver or the stomach. So you want to make sure you use your two fingers of your percussion technique, and you want to make sure you feel in two places in each quadrant. So we have the right lower, right upper, left upper, and then left lower. Next, we will be checking for the costovertebral angle tenderness, or CVA tenderness. So we know that the scapula is here. So all the way down here, we know that the kidneys are here. So you're going to place your hand, and you're going to hit twice. Do it on the other side, hit twice. When the patient has no tenderness or pain, that means that he is negative for CVA tenderness. And this ends the abdominal assessment. So the 6 post-procedural steps are: first, you're going to return the bed to the lowest and locked position. You're going to raise the side 2 railings and make sure the colite is within reach. Then you're going to assess any additional patient needs and let them know of your expected return. Then you're going to dispose of all PPE properly. Then you're going to clean all equipment that came in contact with the patient. Then you're going to wash your hands thoroughly. Then you're going to document date, time, assessment, procedure, and the patient's response to the procedure. For self-reflection, for things that I wish could have gotten better, is that I need to get more practice on listening to people's heart and lungs. And for the abdominal assessment, I need to memorize what is in each quadrant. Thank you.